All right, everyone. It looks like everything is streaming and working well. So let's go ahead and get started. I am going to do this a little bit different than how I have done it in the past for our Rapid 30s. What I actually want to do is I want to go in to my Archer Review login, and we are going to go and choose some practice questions that we want to work on together. So I'm excited. I am hopeful that this will be a little more fun than how we normally do it. So what we're going to go ahead and do is we're just going to go make a test. So what topics do you guys want to see? For those of you who are joining, is there something specific you want to work on? Do you want to work on select all that apply? Do you want to work on NGN? What topics do you want to work on? Kind of what I see in the chats is where I am going to focus. So let me know. A lot of you are saying all, SATA, NGN. So this is what we're going to do. We're going to go ahead. We're going to choose SATA and we're going to choose standalone NG. Oh, it's not going to let me do both. Okay. This is what we're going to do. We are going to do some standalone NGN, and then we'll come back and do SATA if we still have time, because it's not going to let me click both. What's really nice with the Archer Review Q Bank, we now have over 65 unfolding case studies. So if you're like, hey, I have been looking for unfolding case study practice, this is the place that you can go ahead and get it. So let's do standalone NGN, and let's go ahead and let's do 10. I don't know. I hope it's only going to let me do 5. Let's do 5. I've used a lot of my items here. So let's create a test, and we're going to choose our topics. All right, here is our first question. So let me zoom out just a little bit so we can see the whole thing. Here's our question. The nurse is caring for a 72-year-old client in the emergency department. It is 14:30. We have a 72-year-old male brought to the ED with reports of dyspnea and chest pain, diaphoresis, restlessness. The client's daughter reports that he recently took a long drive across several states and his symptoms started abruptly. Client's oxygen saturation was 80% on room air and improved to 86% on 100% FiO2. What red flags do you have? Because I definitely have some red flags already. What are the red flags that you guys are seeing with this? What are the red flags that you're like, ooh, I'm not a fan? What do you think? Yeah, you guys are saying the chest pain, the dyspnea. This is a long drive. Absolutely. You're definitely saying all the right things here, especially with that oxygen saturation, 86%, even on 100% FiO2. I'm like, oof, this isn't good. I'm a little concerned here. The physician was immediately notified at this time of the client's condition and came to the bedside for evaluation. Now it's 14:42, so it's been 12 minutes. The physician ordered a rapid sequence intubation, medications for immediate endotracheal intubation. The physician intubated the client using a number 8 ETT and connected the client to mechanical ventilation using assist control as a tidal volume of 500 mils, a rate of 12, 100% FiO2, PEEP of 5, post-intubation vital signs. We've got a temp of 99, pulse 110, respiratory rate 12, BP 90/62. Pulse ox is now 98%. Now, I just want to talk about something really quickly. PEEP. Why do we care about PEEP? What is PEEP? What does PEEP do? This is something important I want you guys to understand. Let me know in the chats. PEEP, what does it do? It's going to keep the alveoli open. It's like putting pressure on the balloon so that the balloon doesn't collapse. It stays open is how I like to think of it. Now, what happens if PEEP, though, is set too high? Because then we're going to have another problem. What happens if PEEP is set too high? It causes what's called barotrauma. And I think of it like a balloon. If we overly blow into a balloon, guess what? That balloon can break and it causes barotrauma or damage to those alveoli, which is going to then affect gas exchange. So let's look at this together. For each potential nursing intervention, click to specify whether the intervention is indicated or contraindicated for the care of the client. Okay. Request an order for a chest radiograph. I want you guys just to label this as a 1 for indicated or a 2 for contraindicated. And whatever I see the most of, we're going to go with, and then I'll explain the rationale at the end. A lot of you are like, yes, this is indicated. Why do we need a chest radiograph, guys? I know you all know this. Why do we need this? Why do we care about a chest radiograph? We need to verify placement. What's another way they may verify placement? What's another way they might verify placement? Looking at the CO2 for a color change. Very good job. But yeah, equal breath sounds. What's the CO2? Those are a few things that me in critical care looked at all the time when we would have mechanically ventilated clients. All right, the second one, obtain an order for an ABG. Do you guys think an ABG is necessary right now, or is this contraindicated? Give me a 1 for indicated, a 2 for contraindicated. Let's see what you all think. Amazing. All right. Awesome. Lots of you are like, hey, most of you are saying indicated. I'm going to follow it, but you were a little more controversial there on indicated versus not. Collaboration with respiratory therapy to assist in the client's care. Do we want RT? Whenever I think of nursing, is it a one-man show? No, it takes a team effort. Like any job I've ever had as a nurse, it takes team effort, and I want experts. I want an RT. I want people who are experts in what they do because it's going to benefit my client's care. Place the client in low Fowler's position. 1 or 2 for this one. What do we think? Do we put someone who's mechanically ventilated in low Fowler's? Seems like a bad idea. What positioning would we want to use and why? What positioning would we want to use and why? So typically we're not going to do a full high Fowler's when they're mechanically ventilated, typically a semi Fowler's. We want them to be able to breathe well, but I usually don't have them totally flat because I don't want them to aspirate on anything. So typically semi Fowler's is the best positioning here. Now, request an order to administer half saline intravenous fluid bolus. Based off where our BP is right now and our pulse rate, do we think we need a half saline IV fluid bolus? Ooh, you guys are mixed. Most of you are saying contraindicated here. I'm going to follow the group. Turn the client every 4 hours. Are we going to turn the client every 4 hours? No. How often do we reposition? Every 2. Let me tell you, as an ICU nurse, the things that bothered me the most when I saw them in healthcare was our clients not being repositioned as often as they need to be. That is our responsibility because we want to prevent bed sores. We want to make sure that we are keeping our client clean and turned and that we're not causing pressure injuries. The other thing that bothers me a lot, oral care. Oral care is so essential in having good outcomes for our clients. And it's a small thing. It's a small detail that not everyone prioritizes, but it is something that we need to prioritize as nurses. Suction the endotracheal tube every 2 hours. Should we suction every 2 hours? Is this just always, yep, it's been 2 hours, I got to suction again? Or what is the right way to go about doing this? What is the right way? Yeah, the right way is that we suction as needed. We assess for suctioning every 2 hours. If I hear abnormal breath sounds, I should probably suction. If my client is showing signs and symptoms that they're not oxygenating very well, I should suction, right? Prepare for end-tidal carbon dioxide monitoring. Hint, hint, this is how we would check. Another way to check kind of placement, make sure that it was in the right spot. Okay, a lot of you are saying that we are going to, let's see, I don't think I saw, what'd you guys put, 1 or 2? I think I'm seeing pretty mixed. I'm gonna let a few more people put this in. Do we want end tidal carbon dioxide monitoring? 1 or 2? 1 or 2 for this last one. Oh, you guys are pretty mixed on this one, but I think I'm seeing more ones, so we're going to go with it. Let's see. How did we do? Bravo. You guys got it completely correct. Now, there's a couple things I want to talk about that you're like, oh, there was a little controversy here. Why do we care about their ABGs when they're mechanically ventilated? Amazing. Bruno just said, pass my NCLEX through your YouTube videos. I am grateful. Way to go, Bruno. Congrats. Why do we care about ABGs here? Yeah, I'll talk about the saline too. But why do we care about ABGs? Well, because think about it for a second. ABGs, right, are going to tell me what's our CO2 doing. When someone's retaining too much CO2, guess what happens? They become very acidotic because CO2 is an acid. And so we want to make sure that we're really thinking about that. What is their acid-base balance? Is it correcting itself? Is it not? There's a chance that their acid-base balance was abnormal because they weren't oxygenating well enough before this. So I need to see what are the ABGs doing right now, and then we want to watch a trend. Are we compensating in that right direction that we're really wanting to see it? Now, the other thing, is it helpful if I show this rationale? Let me know if it's helpful to see this up. The other thing that we want to think about is why are we not giving the half normal saline? If we're going to do a fluid bolus, we're going to use isotonic fluids. Does anyone know what our isotonic fluids are? Yeah, our isotonic fluids are lactated ringers, 0.9% saline, right? Or normal saline. And then we have D5W. Now, I don't really want to give dextrose here because when we start to give dextrose, the body will absorb that sugar, right? But I really would like LR or normal saline. Half is going to be a what? A hypotonic fluid. And when we give a hypotonic fluid, that will push fluid into the cell out of the vessel. Do we want fluid shifting into the cell out of the vessel, or do we need more volume in the vessel? We need the volume in the vessel. That's why we're not giving the half NS. Does that make sense? Does that make sense as to why we wouldn't give a hypotonic solution? Awesome. I'm seeing yeses. Let's move on to the next question. I think you guys felt good on the rest of these. All right. These are one of my favorites. These are called rationale. Actually, let me go back real quick to talk through scoring. Scoring, you would get 1 point for each one that's correct. You wouldn't get -1 for getting it wrong because you can only put it in one of the categories. So a question like this would be worth 8 points. Getting each one correct got us an 8 out of 8. Now with rationale scoring, like this item here, what this is you actually do have to get both of them correct in order to get 1 point. And so you have to be very intentional of making sure that what you choose makes sense together, okay? Now, somebody said, hey, for that last one, suction's not done every 2 hours, not routinely. We assess the need for suctioning every 2 hours. We do not suction every 2 hours unless there is a need when we assess. All right, so let's take a look at this one together. Let me see if I can zoom in just a little bit to make it bigger for you guys. Can you still, I'm gonna have to zoom out just a little bit more. Can you guys see everything okay when I have it like this, a little bit bigger? All right, let's walk through this. It's 1800. We have a 31-year-old prima gravida at 38 gestational weeks, 100% effaced, 2 centimeters dilated. Contractions are every 15 minutes, lasting for 20 seconds. The client reports that the contractions are more painful and they alternate between cramping and pressure. At 1825, informed consent was obtained by the physician for a planned epidural catheter with the administration of analgesia. Signature was witnessed by the RN. Continuous external fetal monitoring was applied. Normal variability was noted with a fetal heart rate of 110 to 130. All right. Any red flags here? Any big red flags where you're like, hey, this seems like a problem. This is a concern to me. What things kind of have your interest peaked here? Okay, I'm okay with fetal heart rate 110 to 130. I'm okay with it. 100% effaced, only 2 centimeters. Yeah, only 2 centimeters is like, ooh, this could take a while, right? But then we get our vital signs, and here's our vitals. We've got our pulse 91, blood pressure 138 over 76, oxygen saturation 95% on room air. So immediately following the placement of the epidural, what is the client at the highest risk for? Once they place that epidural, what's our number one thing that we're like, ooh, this could happen? Now, several of you are saying hypotension, and I want to talk through a testing strategy. Use that raise your hand in Zoom or comment on the other socials. Who likes testing strategies? Who uses them? I love testing strategy. I think they can make the difference of you passing or failing. And so I want to make sure that you know how to use them and that you're able to apply them. So when we see opposites, opposites don't attract unless it's real life. And sometimes they do, right? Like with people. But hypotension and hypertension are opposites. So as soon as I see those opposites, I'm naturally drawn to them if one is likely correct and one is likely incorrect. And you guys all said hypotension, which falls under that testing strategy. Now, the nurse anticipates a prescription for what? If we're concerned about hypotension, we just covered this, guys. What do we need a prescription for? Absolutely. You guys are saying a saline bolus, and I totally agree. Now, let's think about this. Are we confident in both answers? Because remember, you have to have them both right to get the point at all. So let's see how you guys did. And look at that. You got them both correct, and you got that full point. Very good job. That is a medium difficulty level question, and you guys got it. All right, we're getting the variety today. For sure. Our next one is a bow tie. And I'm going to be honest, I love bow ties. My favorite questions out there are bow ties. Before we dive into the bow tie, though, I saw one more question of why are we concerned about hypotension? Would anyone like to share why do we see hypotension? Why might we see this right after we've placed? So I get what you're saying. You're like, but hey, the blood pressure was okay. But then we just placed that epidural, and now what they're at highest risk for? Good. It's going to cause vasodilation. So as we dilate out, our pressures are going to come down. And so the thing we're going to see is that those pressures are going to drop. Very great question. Good job. All right. So let's check our next question, which is a bow tie. A bow tie is worth a total of 5 points. Each one you get correct is going to get you a point. Now, where I recommend really making sure that you focus is under the potential conditions. That's the most important area to me to get right, because that's going to influence what you choose for your actions to take and your parameters to monitor. So in order to most likely get the best score possible, you want to choose your potential condition first. So let's take a look of the options we have. We have a CVA, DKA, hypoglycemia, or a vancomycin infusion reaction. So it's 0845. We've got our morning capillary blood glucose of 189. We gave 4 units of Lispro insulin per sliding scale. Vancomycin infusion was started at this time in the left peripheral vascular access device that was patent with positive blood return, and the call bell was placed within reach. At 0950, the client alerted the RN that they didn't feel good. The client appeared pale, diaphoretic, and lethargic. The client's words became slurred, and she was disoriented, asking, "Where am I?" The client's breakfast tray appeared untouched. The client's capillary blood glucose was obtained at 41. GCS was 13. Vital signs temp 98. pulse 108, respiratory rate 22, pulse 150 over 80, or sorry, blood pressure 150 over 86, pulse ox reading was 95%. A rapid response was called because the client's condition changed. At 1000, the rapid response team arrived at the bedside. Report was given to the rapid response nurse. So I want you to be thinking right now, what red flags do you see? What are the things that you're like, ooh, that is not good? Those are things that were concerning. And you're right. Several of you are pointing out their blood glucose was 41. Okay, it's 41. That's really, really low. When we look at the med history, we see they have a history of diabetes type 1, hyperlipidemia, pericarditis, and asthma. And when we look at our orders, we're to admit to med surge. We're going to give Vanc. We're going to resume all home medications, insulin Lispro sliding scale before meals, and consistent carbohydrate diet and daily labs. Okay. So these are all the things that they're like, hey, we need to do these. These are the orders. So what potential condition do you guys think is going on? Do we think that this is a CVA? Do we think our clients in DKA? Do we think they're hypoglycemic, or are they having a vancomycin infusion reaction? There was a lot going on in this question, a lot of distractors, hint, hint, hint. What NGN really wants you to do is, can you push aside those distractors to find what truly matters in the case? And let me tell you how real world this is. This is what our clients do sometimes. They're going to give you all this information, and you have to pick out what's pertinent right now. What do I need to focus on right now? And you guys are saying, hey, I think this client's hypoglycemic. So if someone's hypoglycemic, what actions would you take knowing their blood glucose is in the 40s? What do you think? What would you want to do here? Very good. We want to keep the client NPO. Why are we keeping them NPO? Because their glucose is in the 40s, their neurostatus is affected. The problem with their neurostatus being affected is what? They may not have a safe swallow and they could aspirate. Nice work, guys. All right. Now, what other action would you want to take here? A lot of you are like, yep, let's give that glucagon. So giving glucagon IM, whenever you give an IM injection, you give it kind of like a dart into that muscle. And when you give it, what's going to happen is it's going to raise the amount of glucose that's in the bloodstream. And so that's going to help combat that low blood sugar. Now, what I've done, real world nursing here, if in 15 minutes my blood glucose is still low, I've given a second dose before, because sometimes, right? Sometimes one dose isn't enough and we need another one. Now, the only time I've needed several doses was I once had a client whose blood glucose was in the 20s. And so it did take me a couple doses. Now, what parameters would you want to monitor here? What are the parameters that you're like, hey, what do we want to monitor? Now, someone said, why aren't we giving them the skim milk? Well, we put them NPO. So whenever you choose answers, make sure you're not choosing answers that contraindicate each other, right? They can't be NPO and get skim milk. And so because of that, it wouldn't make sense to do those, but great question, because this is a strategy. Do they make sense together? The other thing with skim milk is it's not quite quick enough. I would rather something very quick acting if they had a safe swallow. Orange juice is a great choice. I maybe would do a piece of candy, that kind of thing. Something very, very quick acting. Okay, you guys said we should continue to watch that GCS. I don't really expect a low glucose to affect my creatinine. What if someone was hyperglycemic and they were in DKA? Would that impact creatinine and BUN? Yes, absolutely, right? And let's think about why for a moment. What happens is the body processes those mass amounts of sugar and it can cause the kidneys to be damaged. And then the kidneys produce a waste product. That's what creatinine and BUN are waste product. And so when someone's blood glucose is way too high, it's going to compromise the kidneys. And then lastly, you guys said that capillary blood glucose. What about ketones? When would I see urinary ketones be present? NDKA. All right, let's see how do we do on this bow tie item. You guys got it totally correct. Very nice job getting a 5 out of 5 there. Now, real quick, I want to know who's joining me. Is this anyone's first time at an Archer Review free webinar? Anyone's first time here? Okay, I'm seeing lots of yeses. Seeing lots of yeses saying, yep, first time. All right, amazing. So if it's your first time here, I want to tell you just a little bit about Archer Review. If you've heard this spiel a million times, feel free to tune me out for a moment. But are you guys prepping for the NCLEX, or are you still in your nursing school journey? Let me know, where are you at? Some of you are taking exits. A lot of you are at NCLEX prep. So when you choose an NCLEX prep, I want you to choose a program that's well-rounded. And so what I really like about Archer Review's NCLEX prep, we have RN and we have PN, so you can choose whichever one is is applicable for you. But the SurePass package is the #1 product I recommend to those that are taking their NCLEX. And the reason why I recommend SurePass more than I recommend any other product is because it has everything you need. It includes a 3-day live review. It includes a QBank, and that QBank has over 3,000 practice questions in it. The QBank, with that, there's over 65 unfolding case studies, over 175 standalone items. You're going to have tons of select all that apply items as well. And so it's great because you are really going to maximize how many of those item types that you have. Now, the other thing that's great about our SurePass package is you get Monday through Friday live lectures. So Mondays, Wednesdays, and Fridays, we are focused on case studies that you go through. And on Tuesdays and Thursdays, we're focused on live lecture content. And so everything you need is really included in SurePass. There's study calendars, there's study guides for the week of your NCLEX exam. Everything is really there for you. So if you're like, I don't know what package to get, that's the one I would definitely recommend. Now, the live lectures are from 10 to 12 Central Time every Tuesday, Thursday. Those live case studies happen at different times every Monday and Wednesday, Friday, so that we can really make sure that we maximize how many people are there. Now, some of you are saying, hey, I have SurePass. How would I sign up for those lectures? So what you would do is if you have SurePass, you're going to go into your SurePass account and you're going to click live lectures. And under live lectures, you can register for any of these lectures. So tomorrow, Rebecca is going to go through the nervous system. But on Thursday, I'm going to be doing the respiratory system. So you can go ahead and you can register for those. Yeah, if you have SurePass, you get access to all of these live lectures. Make sure that you're maximizing them. The other thing is you want to know how to sign up for your SurePass live review. If you go here, you will get a free $50 value of a SurePass live review. You get to choose one of them. So you can really go in here and click them here. And then the other thing that you have access to is all of these amazing cheat sheets, as well as our study calendars. If you go to study calendar, you can see the 3, 6, and 12-week plan. We have a 9-week plan that should be added anytime. There's also this amazing week of exam study guide that all of our team at Archer Review came together. We created together. Right now, there is a coupon I can give you for being at this webinar. It is I Love Archer in all caps. I Love Archer will get you 10% off of the program. So it will get you 10% off of that SurePass program. If you have any other questions, if I missed something that you were wondering about, feel free to reach out. You can email us at nclextutors@archerreview.com, or my personal email is rachel@archerreview.com. Now, again, if you're like, hey, I really wanted that coupon, I missed what you said, I Love Archer in all caps will get you 10% off that SurePass package. Now, somebody did say, what's the best package for nursing students? And I'm so glad you asked. So let me go back. When you're here under nursing, click nursing school. We have a full companion product that goes with you through every class you take in nursing school. You can customize this. You can make it whatever to your heart's content. You can buy the whole bundle. That's the cheapest way to do it. Amazing. Several of you are saying, hey, Rachel, I passed my NCLEX, had lots of very highs, passed CATs. Let Morgan know as well. I'll definitely let Morgan know that you passed. Congrats. But again, if you need to reach out, if you have any questions, feel free to email us. We're rooting for each and every one of you. Can't wait to hear when you reach that NCLEX success or nursing school success or wherever you're at in the journey. All right, everybody. I hope you have a great day. Bye, everyone.